But do you want to start by introducing yourself? Tell us a little bit more about you.
Yeah, sure. So my name's Clare Fernandez. I'm the Chief Medical Officer at the BBC. I'm a consultant accredited specialist in occupational medicine, so I'm a medical doctor.
Yes. I read about that. So tell me about that. We had a medical doctor in here earlier, actually. Tell me about
Steve.
that. Tell me about that transition from being a medical doctor to working in the world of workplace wellbeing.
Sure. So my specialty looks at work and health. So, just like a brain surgeon looks at brain and cutting out bad things, my specialty, slightly different, is very much focused on the interaction between health and the workplace in lots of different guises. So, looking at the evidence for what works and what doesn't, but also looking at individuals. So traditionally, a doctor in my specialty will work in occupational health company and look at how to facilitate somebody in the workplace with health problems, or help managers to manage employees with different health and well-being problems. So it's not that much of a stretch when you look at it that way. It's just working in a slightly different capacity. So in the NHS, I'd be looking after doctors, nurses, porters, anybody that works within a hospital setting or a general practice setting. But in industry, as we call it in my world, working in the workforce that's not the NHS, you're looking after workers within that field. A good example would be pilots. They have specific medical things that they need to fulfill to be able to fly us safely, to doing things like policy and practice.
Yeah. Oh, great. No, it's definitely not a stretch. I'm not suggesting it's a stretch, I promise you, with that question. We're just always interested in terms of how people got to where they got to today and the journey that kind of took them there, because it's been really varied from the people that we've told. Some people start as a PT in a gym and now they're global head of wellbeing in an organisation with many thousands of staff. Other people very much set out on that route. There's a lot of HR. But yeah, more and more. Maybe this is recency bias, but I'm seeing a lot more around the occupational health piece and the medical background, which I think in a way is really good, because you mentioned the evidence base behind that. I think we need to have that as a core pillar.
Well, I think your sort of question, what you just said, it is very valid. So there's lots of people working in the world of health and well-being of all sorts of, either they've sort of come to that realization that they want to do that through their own personal journey, or they've been in a well-being sort of role or an HR role before. And there's room for sort of everybody. We all have our own different strengths and weaknesses that are important to work together in this space. And I think that, like, for medical professionals, we're actually sort of in a bit of a decline, because our specialist skill is that medical side of things, that robustness of evidence, talking about specific conditions, which a lot of companies don't particularly feel that they need. We're also quite expensive. Nobody wants to, if you can do it just as well in a different way but cheaper, who's not going to go for that? So I think we're sort of in a bit of a decline, but in this current economy of actually we're in a worklessness crisis, and a lot of that is to do with health reasons or social care reasons. We are perhaps playing a more prominent role now, because people are sort of seeing, actually, I've got 16 years, I think, of medical experience. So I know I don't look it, but
I know we're meant to say that. Damn. I just nodded.
Yeah.
So sorry.
No. But I've seen patients of all sorts, or in a lot of different spheres with a lot of different problems, not just health problems. But actually, that's what we really bring to the table, is that thousands of patients, those years of dedicated experience to health and well-being to an extent.
Yeah. I know, Liz, you got some thoughts on the application of the medical model in the workplace. I don't know whether you want to ask about that.
Well, I was more curious as to, was there anything that drew you into the workplace? Was it about an opportunity? Did you want a bit of a shift? What was it that drove that for you?
So going back to what you said about people's journeys, so my journey was a fairly standard medical one, and then veered very much off course to the point that I do talk to a lot of doctors about what they want their careers to be like and what they can and can't, or you know, what they can do, what they feel that they can't do but they can do. So I went to medical school after my A levels, and in fact, I was talking to a group of doctors the other day, and I think at medical school I wanted to be some sort of surgeon, because I think everybody does. They sort of say at the beginning everybody wants to be a surgeon, but most of you will be GPs, because actually that is what we need more of. But I like the idea of cutting. Who doesn't like slicing and dicing? But actually, I could barely cut my own food, so it was not going to be a good idea. When I left medical school, we go into just general training, we try out different specialties, and we work as doctors. And I decided that I wanted to do imaging as a specialty. It's quite cool. There's lots of good things going on in the field. You know, there's lots of groundbreaking stuff that's happening that my colleagues are doing, which is super awesome. So I did that for a couple of years, and then realised I wasn't really liking it as much as everyone else was, and it wasn't really for me. And actually, it was making me quite unhappy as well. So at that point, I'd suffered from depression before, since I was 17, and that really then kicked in. So I left that specialty, took a year out, went to New Zealand. Did a couple of other specialties there, so I worked and travelled. Came back, still didn't really know what I wanted to do. And medicine, it is sometimes seen as one of those things where you kind of have to do something. And thankfully nowadays it's becoming less and less like that. So I then went and trained in general practice, because I thought, well, it sort of fits with what I want for my life. I can use it as a base. But I was also very unhappy doing that, to the point that people started saying, do you actually want to be a doctor? You know, you're really like not finding your groove. But I'm fussy.
And what was it about that, if you don't mind me asking? Specifically that you didn't enjoy about that
general
experience?
practice.
Yeah.
It's a really tough job.
Yeah.
So you're at 10 minutes to see a patient. I don't feel that I could do enough for them in that time. I felt that they felt they weren't being listened to. The whole experience was quite dissatisfactory. I felt, you know, the hours are really long. It's a very intense specialty, and I just felt that it wasn't making me shine. It wasn't making me sparkle, which everyone commented on, to the point that my dad's old junior doctor met with me one day and said, "I've never seen you so unhappy." She was an occupational health consultant, and she said, "Well, why don't you look at this?" And I thought, oh, I like this. It's still pretty general. You've got a bit more time. I felt like I was making an impact, and in where I've been previously, I felt like I wasn't making an impact for whatever reason. And with my own background of having health problems that had impacted on work, not so much my study to an extent, it really resonated personally too. So I went into that specialty, started, you know, working as a jobbing occupational health doctor. Really enjoyed it. My patients, my employees, I think, liked seeing me, which, to be fair, has been the case all the way through. But I felt it was a bit more like satisfying for me. And then I felt like I could make a big difference individually, because work, I feel, is so important to people's lives, whether people realise that or not. And no matter what people do, no matter who they are, it's so important. And so I stuck with it, and here we are today.
Here we are, yeah. I had a question actually before we walked in about scale, and how you scale this sort of thing up, because I agree there's a real opportunity to have an impact on people's lives because they spend so much time at work. But then you said you work for the BBC, right? Lots of employees at the BBC.
Yes.
So how do you scale that impact? There's an easy question for you, but how do you scale that impact across such a large population?
Yeah, that's fair. So we have 22,000 employees across 56 countries. So, you know, there's big hubs like the UK, like India, like Nairobi. But we also have a few people dotted here and there. And I think, there's several ways to skin a cat. My sort of personal view is that how you then scale it up is that understanding of basic principles, of how people work, what good work is, looking at it specifically from a health point of view, given that's my niche, would be then, well, what are the common problems, health problems that people have in the workplace, or what are the common problems that they have outside of the workplace? So thinking about other countries and what are the important things that are going on in that country, to then decide, well, what are your employee rewards for that country, for example, or what different guidance do we need to put in place so that I can take my medical knowledge and transfer those basic, I say basic like it's, I don't mean basic like, sort of basic, sort of Karen basic, I mean it, no offense to all the Karens out there, but I mean more in terms of how do you translate that on a wider scale so that the manager sitting in Abuja can deal with their concerned employees about X, Y, and Z. It's about translating that. And I think as a business psychologist, for example, that might ring a bit true. But I just work across physical as well as mental health.
Yeah.
Can we go back to that medical model?
Yeah, sure.
Yeah, just curious. So I found it curious that there was this strong focus on using clinical measures within the workplace. So looking at the impact, well, I suppose looking at employee mental health, but not considering the impact of the environment. And a lot of provision, I think, focuses on the individual and uses clinical measures. Just wondered if you had any thoughts on, I think there's space for it, absolutely. But yeah, just curious to get your thoughts.
I have lots of thoughts on that. I have lots of thoughts in general. You may have gathered. So I actually don't see that a lot in workplaces. So I think that's really interesting. But I do see a lot of non-clinicians using words like evidence-based and clinical practice to try and make it seem like more of a medical model, because I think that nowadays, I mean, you see that in all sorts of industry, like the beauty industry, they'll say clinically tried and whatever, and you're like, I'm not really sure that testing it on 5 people over a period of 2 days counts as a clinical trial.
2 of which said it was all right.
Yeah, exactly. But I think that there's a place for that. My idea of medical model is actually the new medical model, which is the biopsychosocial approach. So looking at the physicality of the person and that, what's going on inside, the social, so their surroundings, and psychologically what's going on up there. That's, the kind of a simplistic version of the new medical model. That's what I think we need to align to as part of like an igloo approach. So a more kind of structured framework, looking at all the things of the individual, the group, and the wider surroundings.
I love an igloo model. Yeah.
Yeah, exactly. It's very cool. I mean, other models are available, of course, but
this isn't sponsored by Igloo.
Yeah, exactly. Yeah. But I think that there is a place for looking at what is the evidence, but that doesn't. There was a great quote from one of my colleagues actually, and I can't quite remember it, but I think it was from Joe, who you might be seeing later. That evidence doesn't necessarily mean that you've got this systematic review of all these papers and things. Evidence can be what works for your employees and your circumstance. That's a form of evidence. Yeah. And I think it's about, you talked about sort of looking at clinical outcomes. A good example of a clinical outcome is well, do people feel better? But that's not particularly clinical, is it? That's a qualitative measure, but it's an important one. We don't need to look at, has their depression score gone from this number to this number? That can be a good way of extrapolating to how they're doing, but that's part of a huge spectrum of measures we should be looking at. And I think that's where the kind of medical model fits into wellbeing. And as all the wellbeing professionals do, as we talked about right at the beginning, it's part of a plethora of different things that need to be involved.
Yeah. And can I ask you a work question as well? So how do you split your time broadly between, so I'm guessing you've got people who you work with have a huge range of challenges. So you must work with people who are on the front line, you know, in potential war zones and whatnot. I'm guessing potential trauma associated with that, right through to people who are just your day-to-day, you know, in an office, behind the scenes, where their pressures typically are more around kind of overload and lack of autonomy and relationship issues and these sorts of things. How do you find you split your time between those two, or do you see that as all one of the same challenge?
Bit of both. So I don't work clinically, so I don't see patients for the BBC. We have our outsourced provider that does that. Where I might come in is that input into the workplace. How does that, what the clinician or somebody has said on the other side, how does that actually translate? But I only do that for quite niche cases where, you know, so I've worked with people on various TV shows where one of them's Blue Peter, where they do a lot of unusual things that you can't just extrapolate advice for, or individuals working in areas where, you know, there's security risks, or they're working on the ground where things aren't as straightforward as working in an office. So I might use that advice to help managers and the individual to deal with that. But actually, the rest of the time, that's quite rare, actually, that I have to do that, because our OH is very good and can cope with all of that, and our managers are very good too. But I see sort of, you've got one side, you might have your work-related stress and autonomy and you know, problems with workload and demands and things, and on the other side, I guess that might be your individual, you know, covering the famine at the moment going on in East Africa, potentially, who's out there for a while, or, you know, working in Ukraine, or in, unfortunately, the conflicts that are going on around the world. But actually, in this individual, they're probably still quite overworked and overburdened and feeling lack of support, just like this one over here. So sometimes there's a lot of crossover. But also there are some niche bits as well. So somebody working abroad in an office might have an outbreak of monkeypox. They're still, you know, whereas somebody working in war-torn Gaza might not have those problems, but might have problems with security and safety. So actually, there are little pockets where this person here in your, I don't know, boring office in Birmingham, no offence to the Birmingham office, I love them, it's my favourite office, actually has more problems than the person that you think would, you know. But the way I look at it, it's about prioritising. Where are the big pockets of problems? That's where I work on a leadership, strategic level. Where are the big, how do you prioritise? Just like, you know, everybody has to prioritise their daily life, or the government has to prioritise. It is a case of where you're going to get the biggest bang for your buck, and where are the things that my input is needed more than someone else's.
Yeah, that's really interesting. You must not. It's a really interesting job, right? It must never be boring. You must get a real breadth of things that you get to work on.
Every day is different. People say, what do you spend your time on? Sometimes I'm not necessarily sure where the time goes, but it definitely goes. So it's a nice job. I'm very fortunate to have it.
Absolutely. I've done a little bit of work with BBC over the years, like here and there. And one thing that always struck me was how seriously they take their duty of care. You know, I'll give you one example. This is going back, it's probably a decade now, probably longer than I'd care to remember. But I got asked to run a session with a team who were working on the radio. And they were looking after the Teen Awards. Do you remember the Teen Awards? They still do that? So it's essentially where they put out a call for young people who'd done amazing things in their lives or overcome real significant adversity. And these stories are amazing. But what they'd recognised was that the people in that team were having to read these quite harrowing stories, like day in, day out, and they had no outlet for that whatsoever. But the thing that really struck me was that they'd spotted that risk, and I'm not saying that I solved it, right? But, you know, they'd at least tried to provide some provision, and partly it was about how do they support one another, to be perfectly honest, and draw upon the support that was already available. But that struck me, that it felt like an organisation, and this isn't an advert for the BBC, but it felt like an organisation that cared. Yeah, absolutely. I think duty of care in the production industry has been a big thing over the last few years. I think the Jeremy Kyle story just sort of ended, if you like, a few weeks ago. And
we're pushing the boundaries in various mediums, trying to give people information, and that can come with a cost. We also have lots of kind of legal duties to do so, and we have very, very good teams. Our editorial board, shout out to the editorial board, they're very, very good in their duty of care to pick up those things early, and the BBC is very hot on prevention is better than cure, which I think is a real strength. So yeah, they're very good at that.
Sounds good. I don't know if you've got any other questions.
Might be a bit of a curveball one. Just relating to AI and I suppose the future of wellbeing, can you see, or have you got a take on what you think the role of AI might be in workplace health?
There's a curveball.
That
I
is
like it.
interesting. So I'm a bit of a technophobe, so I'm probably not going to give the greatest answer that you'll hear today if you ask that question to someone else. But I think that AI is good once it's learned, and there's lots of sort of general principles that AI will be able to take and apply to a situation. But it will never take over completely, because well-being, particularly in the health sphere, because obviously well-being is financial well-being as well as your security, your safety, and you know, not to just talk about health, requires that human touch. You can't have that support, one of those key management standards. You can't have that without actually having a real person. You can't have a bot giving an answer, no matter how realistic it is. Sometimes, for example, you know, you need to look into another human being's eyes, or you need that squeeze to your arm. We're not really allowed to touch anybody I know anymore now, but you know, that pat on the shoulder can make a big difference. So I don't know where it's going to go, because I only use ChatGPT in a really basic way, and I do mean that in the way that it's used colloquially now. I'm not the best at it, but it won't replace it as much as people will try, because it is a game changer. It's cheap, it's quick, and it's smart, but it won't replace it completely.
Yeah.
Any thoughts?
Sarah, have I got a thought on it? Oh, I don't know. We went to the conference. We both attended a conference not so long ago, and it was really interesting. They did a Turing test at the front of the room. So essentially, where the test is about, can an audience be tricked into thinking an AI machine is a human being? So we had a human answering question, a person we know answering questions, and then he was up against the AI, and you had to kind of tell which one was which. And basically, it's very, very difficult to tell. It was scarily difficult to tell. I think I'm with you. You know, they're not got the robot arm around the shoulders. It isn't ever going to be quite so good. But I think it's more about how do we integrate that into the practice to make what the important bits of what you're doing easier to do.
Job strain.
Absolutely.
How can AI be used to reduce job strain, or even email? I'd love, if I could design anything, it'd be around email management. Just take my emails away and I'd be very happy.
Absolutely. And I think that, again, going back right to the beginning, I do like a story arc, is there's a role for everything. It's just who's doing what, and everyone, it's best, it's enhanced when everything works together.
Yeah. Nice one. So, final question. We're asking all our guests today what they do for their own well-being as well. So is there anything specific around that?
Yes, I run and I do yoga.
Nice.
And I meditate. It makes me sound like I do a lot of stuff. It's all very sporadic, but every day I do one of those. Oh, I also cuddle my cats and my daughter as well. So yeah, every day I do one of those.
Yeah, nice one. And I said last question, but we never asked about the T-Rex that you got in your bag. Why have you got a T-Rex?
So I was one of the panelists on the keynote this morning, which was a debate on which is better, institutional interventions or individual. And my dino was my example of prevention is better than cure, i.e., is it better, if I do this, is it better to have institutional interventions that talk about, well, actually, Claire, it's not good to do that. You're going to get punished. You know, you're going to get disciplined if you do that. This is how we want people to behave. Or is it better that once he's hit, the dino goes off and uses an app, or, you know, learns how to avoid the bully or learns how to manage the headache that he's got or the anxiety that he's got now after this, which is the individual intervention, which is better. So that's why I have my dino. And also, it's only, people are asking, why is it a dinosaur? I was like, because basically it's one of the toys that I know my daughter won't miss.
Okay. I was going to ask that thing, like, is there some
people are
metaphor
like,
behind it?
like,
being
no,
it?
I'm just not that deep,
No,
quite frankly.
no,
Yeah.
That's all right. That's all right. No. Excellent. Thank you so much for your time today. Really appreciate it. Lovely to meet you.
Yeah, nice to meet you guys
and
too.
we do, we'll get this uploaded, and we'd love, I'm sure people would love to hear some of the things that you've got to say. Plus, we've got a full-length version of the podcast, so we'll have to get you on that at some point. This is a micro version, so we'll get you on the full-length version at some point, because there's lots more we can speak about, I'm sure.
Awesome. Thank you.
Amazing.